as the secretary.
Good afternoon
Prafulla.
all. So I'll try to keep it as short as possible. So here I'm going to share with you our experience of handling 6 cases which were referred to us with a diagnosis of chronic angle closure glaucoma with corneal decompensation from our glaucoma clinic. Now these were the cases, one of the cases CP is here. You can see it's very easy to get confused because there is you can see here the iris is atrophied, there are few patches of pus and the cornea is edematous and the pupil is even fixed and mid dilated. But if you observe carefully, you can see there was some synechiae was there, and this patchy atrophy is classical of herpetic keratouveitis. And if you observe carefully, there are few decimate folds also. So all these points clearly suggest that yes, you are dealing with a case of herpetic keratouveitis rather than PSEG. Similarly, this was another patient. You can see clear case of endothelial folds with epithelial hypertrophy due to recurrent corneal edema. So how to manage such cases? Now I'll just show 3 videos. So the best technique is probably DMEC. Why? Because most of these cases are young patients and they do have a phakic and you have to do a phakic procedure. And DMEC in phakic eye is quite easy if if you understand the aqueous dynamics. Then with the lens in place, it's very easy to unroll the graft. So this is the standard DMEC procedure I am doing. It was a 38-year-old male patient with recurrent keratouveitis, and I did a DMEC in this patient. The important point is you have to achieve pupillary constriction, and no matter what maneuver you are doing, you have to bypass this pupillary plane. Don't go through this plane or else you may hit the lens. Then the standard DMEC was done, decimate scoring is done, and this is the a 9 mm ring mark which I have put. This is one of my early DMEC, so I used to do all the steps as described by experts in the field. So once you're, and this decimate scoring is done under Helon. If it is a pseudophakic patient, you can still do it with under air, but you're not doing in a phakic patient, it has to be under Helon cover or else may hit the lens. PI is a must because these are phakic patients, and this is once you have scored, then you can take out the Helon with the IA probe. And this is the Alcon D cartridge. There are several cartridges in market available, but you can easily convert your Alcon D cartridge or any oil cartridge simply by connecting to the IV line and using that. And this is a 2.2 D cartridge, so I can inject my graft even with a 2.2 incision size, and I just need one suture. At times you can leave it sutureless also. Now phakic cases, the DMEC is not that difficult, just a 2-3 minutes maneuver and you can easily achieve a unrolling of the graft. The only thing is, only thing you have to remember that don't collapse the AC too much that you may hit the interlens capsule. If you hit the interlens capsule, then the lens is going to be cataractous very soon. So this is one case, but not all cases are that easy. This is the follow-up of the patient, and this one suture the patient never allows me to remove it because he has gone through Google Baba and he understands that any corneal trauma can incite a recurrence of your endothelitis or keratitis, so he doesn't want me to touch his eyes. So this is a second case. Here you can see the edema is little bit severe. So here in this patient's DMEC can be done, but you can see the visibility is not that good. So in such cases, I would prefer to go for a DSEC, which is more predictable for me. And as you can see here, most of the steps are same. Only thing is I would go for a corneocerebral tunnel here, okay, because so that I don't induce much astigmatism, and I prefer a automated graft preparation, as you can see here. So again the same precautions, don't cross your pupillary area, achieve pupillary constriction, and do a PI in all your cases, and ensure that you have removed all the Desmet tag. And this is the graft. This is the Bushin glide. I use a push and pull technique by Bushin glide and a microvitretinal forceps. And again, DSEC is not, and probably this is one scenario where DSEC is challenging than your DMEC. Why? Because in DSEC there is a definite stroma component. So the space, chamber space where you are going to manipulate is very less when you are doing a DSEC in a phakic patient compared to doing DMEC in a phakic patient. So this is little bit challenging in such patients. Otherwise, rest of the steps usually they goes fine. No issues with that. And last is extreme of cases where the patient had cataract, also corneal opacity and corneal edema. However, it was eccentric opacity, so I thought let's go ahead with a endothelial keratoplasty procedure. Again, I won't prefer DMEC in such patients because it will be quite challenging. Main challenge in this patient is doing phaco. So whenever there is corneal edema, few things you should take precautions. Use a viscoelastic, that will give you a temporary improvement in magnification. Use Trypan blue in all your cases. Use Rexis forceps. Start from a clear area and then complete your Rexis. Never ever start from here. And during phacoemulsification, there is a technique called phaco in situ. That means as you are dividing the pieces, keep on emulsifying them. Don't wait to make 8 pieces and then start taking emulsifying one by one. So and when you are dividing, then emulsify that piece so that you can rotate and bring all your nucleus material into the clearer area, which is in this case you can see here. So that is my operating area. Once your phacoemulsification is done, then you can always put a IOL and then complete your procedure. So few things to remove, few things that we understood from this from these 6 patients is that almost all patients are pre-cataract stage. So you have to tell them, as per the recent literature, whenever you do a endothelial keratoplasty procedure, the chances of getting cataract increases by 7%. So they may get senile cataract little early. Intraoperatively, you have to avoid lens trauma and pupillar area, do a PI. Post-operatively, steroid and acyclovir prophylaxis. But surprisingly, none of these cases have ever recurred. And one of the cause could be, as per the recent pathogenesis, virus stays in your endothelium probably. And once you are replacing the endothelium, that probably leads to a reduced recurrency. However, this has to be proved in future studies. With this, I will conclude here. Thank you so much.